everyone, and thanks for the introduction, and thank you, Sovereign Health, for having me talk. I want to talk today about buprenorphine maintenance. We're all familiar with buprenorphine, and we're all familiar with the opioid epidemic that is taking over this country. So to just set up for today's talk, I want to, first of all, just remind everyone what an epidemic opioid use disorder is, and then to talk about buprenorphine, which is used for the detox off of opioids and also maintenance. Another drug that's used for maintenance is methadone, but I won't be talking about methadone today. And I also want to cover the big difference between the medical community's views on buprenorphine and the recovery community's views on buprenorphine, because I've noticed through my years of working with opioid addiction that there's a huge divide between the two communities. And I also, the objective of today is to establish a basic understanding of how opioid addiction forms in the brain and how buprenorphine is used to treat it. Before we get started on that, I was reading CNN a couple of months ago, and I found these graphics that I want to share with you. This graph shows from the year 1999 to the year 2014. It's just a map of the United States and the number of deaths from drug overdose. And the darker it gets, the higher number of deaths. And just look at the difference between 1999 and 2014. Opioid addiction and addiction in general is getting a lot of attention politically, and this is why, because addiction is killing a lot of people. This slide was also from CNN. It compares the rate of death from drug overdoses, which is this line that goes up, compared to the number of deaths from shootings and the number of deaths from car accidents. You can see that the number of deaths from drug overdoses is drastically increasing, and it is becoming more and more of a problem in the United States. This slide, also from CNN, I love this slide because the darker red is the number of deaths from heroin overdose. The pink is the number of deaths from all opioids. So this graph is really important to me because it shows that so many people die from taking the pills and not heroin. More people die from the prescribed form of opioids than they do from heroin overdoses. So this graph was very important to me, and also the number of deaths overall in the United States with respect to drugs. 61% of the number of deaths in the United States are caused by opioids only, and only 39% are caused by cocaine, meth, all of the other drugs, ketamine. You put them all together, they cause 39% of the deaths. Opioids by themselves cause 61% of the deaths. And a heroin user is 63 times more likely to die than a control subject that is not a user. So the disconnects between the medical community, this is what I've been facing throughout the years working in the recovery area, is that doctors love to use buprenorphine. Recovery community does not like buprenorphine maintenance. The difference between detox and maintenance is everybody's okay with a patient coming in, being put on buprenorphine, and then rapidly weaned off and becoming sober. Medical community has much more interest on putting a patient on buprenorphine and then maintaining them indefinitely on a low dose or sometimes even a high dose of buprenorphine. And there's a great divide between the two views on buprenorphine, and the reason for that, at least from what I see, is that in medical community, first of all, the training on addiction in medical school, we didn't, at least in my medical school, and I went to UCI, which is a pretty reputable medical school, we did not have any specific lectures on addiction. Maybe we had 1 or 2 lectures in 4 years, but there wasn't a unit, like there was a pediatric unit, there was a surgery unit, there was no addiction. This is one of the greatest killers in the United States, and it's not being addressed in medical school. And the other thing is that even in residency, I only got training in residency for addiction because I did a 4th year of psychiatry. Many other areas do not touch addiction. So what we're left with in medical school is we're taught to follow evidence-based medicine. Evidence-based medicine, those are the big words we always love to use, evidence-based medicine. And that means look at the studies, look at what they recommend and follow the studies. The problem with the studies is that they always have a selection bias based on who's in the study. For example, a patient, especially in the field of addiction, we lose a lot of patients to relapse, correct? And the patients who sign up for studies may have more of an inclination to stay, some sort of an incentive to stay in the study rather than people who are out on the street. So the people that the study picks may not be representative of the population at large, and evidence-based medicine is also something that needs to be funded. All of these studies need to be paid for by someone, and a lot of times they are paid for by drug companies. So there's also some bias there. And then also, as doctors, we want to save lives. We want to, we want to be gods. We want to save lives. So to us, it's important to help someone stay alive longer. So a lot of doctors subscribe to the, the harm reduction model rather than the sobriety model. So again, we look at, are they alive? Are they working? Are they in a relationship? Okay, they're good to go. On the other hand, the recovery community looks at buprenorphine maintenance as, well, you're having me give up this drug and just you're making me dependent on this one. What's the difference? Why am I giving up? And there's also a all or nothing idea that you're either sober or you're not, and I feel like both communities think inside the box. We have our own evidence-based box, and the other box would be an abstinent-based box, and it's just nobody's talking to each other, and we're not compromising. Then I wanted to just do a quick overview of how opioid dependence forms, and I'm a picture person, so I had my daughter draw some pictures to share with you. I gave this talk last year, so if it's repetitive, I apologize. Think of that big blob as a brain cell. Those little sleeping babies are receptors on the brain cell, and the person down there is actually the brain, and it's also representative of the person. And those little tentacles are how the brain cell communicates with the brain at large and with the person. So the little babies, all of us have opioid receptors. Opioid is a natural product, and our brain makes receptors. And the brain is also extremely plastic in the way that it responds to its environment. So normally we have a few opioid receptors. They're hanging out there. If we're in pain, they let us know. If we're not in pain, they're just kind of at rest. When we're in pain, the babies are crying. And they are sending us little angry signals, little demon signals saying, we're in pain, do something, do something. As part of our evolution, we have needed to respond to pain. Pain is a signal that tells us, get out of here, you're in a dangerous situation, take your hand out of the fire. All of those things are communicated to us through our pain receptors. So these babies, when they cry, they're telling the brain, respond to this pain, something's up. Now, when you take opioids, those little milk bottles are the opioid molecules. When the person takes opioids, the babies are happy. The signal for the pain may still be there. My hand may still be hurting, but the babies are tricked into being happy. And they're sending the brain little happy signals. The little brain down there is happy, smiling. And that's what they're supposed to do. That's what opiate is supposed to do. You have a surgery, you take opioids, you can manage the pain. Problem is that the opioids have this euphoric effect, and some people feel good when they take opioids. And it's amazing how my patients describe different ways of feeling good. Like for some people, it's a warm blanket, while for the other people, it helps them focus and get going. But anyway, it it gives some people a different effect than just the analgesic, and they start liking it. So they say, I'm going to take more of that. And then the brain cell, being an incredibly powerful at adjusting itself, it goes, look, opioids are around. I better make more receptors. So the brain starts making more receptors. And the person down there is getting happier and happier as he continues to take his opioids, and the receptors continue to build. So what's happening here is that the brain is going, there's more opiates. I need to make more receptors. The person is going, gee, this is really feeling good. I need to take more and more opiates. So the whole cycle becomes a vicious cycle where the person has to take more opioids to fill all the receptors, and the brain is building all these receptors to accommodate for the level of opioids. This is why an opiate naive person can take one Vicodin and have their pain go away, and a heroin addict can take 10 and first of all not die, and second of all not even have their pain reduced. Now, not only we get our receptors all messed up with taking more opiates, we also have the problem, there's a whole different pathway in the brain, and I couldn't come up with a better picture for it, but basically this is the reward pathway. So the person is feeling meh, okay, takes opiates, gets a little medal, you're number one. The reward pathway is also a very important evolutionary pathway that we have in our body, in our brain. This is what tells us, you did a good job, do it again. When as little children, we brought our little picture home, mommy, I made this for you, and mommy gave us a big smile, put the picture on the refrigerator. We got the reward. We thought, we better make more pictures for mommy. With the opiates, this goes wrong, you know. The brain really does not need to tell us to take more opiates, but it activates the same brain area, so we think we should. So here we are. Here's our person who's become dependent on opiates, has exponentially larger number of receptors for opiates, has to take all these opiates, and is getting rewarded for it. He's feeling good, you know. If I have memories of trauma, I'm not feeling my trauma anymore. If it's what makes me focus, I'm all of a sudden focusing better. The person is pretty happy. Now, I always like to tell stories. I make these pictures up myself. I thought about, in terms of opiate addiction, I thought I'd actually tell you about 5 people that I've treated and tell you their stories, and to make it more real and more personal. Our first guy here, Ivan, I first saw him back in 2010. He was only 25 years old. His chief complaint was opiate use disorder. He had no legal history. This guy did okay with life, but started with opiate use and ended up dropping out of college. Life wasn't going so well. So I saw him in an inpatient setting back in 2010. And I'll tell you more about each one of these guys later. Ariel, I just saw him, I saw her a couple of years ago. This is a very interesting case. She came to me and she said, I suffer from anhedonia. Anhedonia is a symptom, meaning that I don't feel like doing anything. I don't feel like getting out of bed. Anhedonia is not a diagnosis, but a doctor had diagnosed her with anhedonia and had put her on Ritalin to treat the anhedonia. The third case, Wesley, I saw him back in 2013. He was also 25, and he was also inpatient when I saw him. He had a long history of opiates, and when I saw him, he actually wasn't doing opiates. He was drinking, but he had a lot of legal problems, and that's why he actually ended up in treatment after being arrested. Maple is probably one of the most interesting medical studies. Books can be written about her. She has a disease that nobody can explain, where when she was 16 years old, she spent a year in a coma. And she woke up with severe pain, vomiting, seizures. This girl is severely disabled, and she's also in a lot of pain. So when I saw her, believe it or not, she was on 100 milligrams of methadone twice daily for pain. And Dipper, I first met him in 2015. He has a long history of being in jail. His parents kicked him out, couldn't deal with him anymore when he was only 16. Opiates, this guy mixed his heroin and meth together in his IVs and had a lot of different problems. The good thing about Dipper, all these other four have comorbid psychiatric problems. They have depression, they have anxiety, they have bipolar disorder, something. Dipper, when I saw him, he was psychotic, he was paranoid, but once the drugs got out of his system, it turned out he was okay otherwise. So remember, let's go back to our brain. Remember all those receptors with their opiates and our happy guy. You take the opiates away, and you have a lot of unhappy receptors, not just one or two. Your brain has an exponentially higher number of receptors, and they're all screaming. Not one or two, but they are all screaming. This state, I'm sure anyone who's seen it or who has experienced it knows it's worse than death. I actually know a person in this room that tried to get out of recovery when he was in this state. And it's just awful. They feel like they're dying. And this is very interesting to me. You know, medical doctors say, oh, opiate withdrawal doesn't kill you, so you can do it outpatient. And I go, are you kidding? Have you seen what they look like? I know it's not going to kill them, but they're going to run. They're going to find the first dealer they can find, and they're going to calm these receptors down. So I believe outpatient detox is almost impossible. And the urge to use at this point, seems to me, the urge to use is stronger than the instinct to live. I've had people use their urine to melt the heroin in, use their spit, gutter water, anything to get out of this state. So what does buprenorphine do? Buprenorphine is a partial agonist. So it's not giving the babies the milk, but it's giving them a little pacifier. It's saying, you're okay, don't worry. So the person is not exactly getting the high, but he's also not in that state of, oh my God, I'm gonna die, get me out of here, I need to use. It's kind of in the middle. I don't know if any of you have seen buprenorphine induction. The person is in pain, they're sweating, they're horrible. You put a buprenorphine under their tongue, they calm down. They stop sweating, they get better. And that's what it does. Now, notice the little stop sign on the guy's heart. He's still not getting rewarded. He's still not getting high, but he's feeling less uncomfortable with the withdrawal. And the idea of buprenorphine maintenance is basically keeping someone in this state indefinitely. So I just wanted to put this picture up so you can see that's the philosophy. And this is a good slide to also, this is a good place to remind you, buprenorphine maintenance by itself is not enough. I mean, even in this case, okay, the guy is not withdrawing, but we're not addressing all the underlying problems, all the underlying issues that caused the person to start self-medicating in the first place. And then the idea with buprenorphine is that it's a partial agonist, so it goes to the receptors, but it binds them more strongly than opiates. So again, theoretically, when you're taking buprenorphine, if you take opioids, you can't get high. The bottles are in the system, but the babies can't take the bottles because those pacifiers are blocking the access to the bottles. And this can go either way, because what happens with, although this, fortunately, in reality, this doesn't happen a lot. My worry when I saw this picture was, okay, well, then they're just going to keep putting more and more opiate in the system until they knock off the pacifiers, and then at that point they're going to overdose. Doesn't happen. In reality, actually, the drug overdose for someone who's rate of drug overdose for someone who's on buprenorphine for them to die of opiate overdose is actually not happening very much. I don't know, I can't explain why. So let's go back to our cases. I want to tell you a little more about their story. Ivan, again, I first saw him in inpatient recovery. He was 25 years old. He comes from an, what do you call it, middle-class family. Father is an alcoholic. Father actually sobered up when Ivan was 2 years old. And then when Ivan started dabbling in drug use, the father blamed him and relapsed. You drive me to drinking. Which is an awful thing to do to your child. And actually, the father just passed away from complications of drinking. So he dabbled in high school and college, but at college, you know, when he's in college, he's out of home. He has more freedom, and he starts doing opioids daily. He starts by swallowing them. Next thing you know, he's smoking, he's snorting. When he started using IV, that's when he thought, okay, I really need help. I've taken this too far. He also smokes, and he had depression when I saw him. And he had actually sought help with that outpatient buprenorphine in the past. The doctors had put him on buprenorphine a couple of times, and he had relapsed. But this time he was in detox, so we put him on buprenorphine. We also started treating his depression, and we did routine drug tests and routine follow-ups. And Ivan, what I love about him, and by the way, these guys, I consider them all my children, so I call them my babies. Ivan is very compliant. He always comes to his appointments. His drug tests have always been clean. So we started treating him back in 2010. And with Ariel, this was a more complicated case. She came to me, and she was not raised very well. The way she described it to me is that she said, I've been tossed around like a hot potato. Nobody ever wanted me. So not a lot of history of trauma, but a lot of history of neglect. And her father is not an addict to substances, but he is quite a workaholic. She tried buprenorphine several times in her life. Each time she relapsed. At age 30, she was started on maintenance, and when she came to me, she was on 16 milligrams a day. She had anhedonia, and she was on Ritalin for that, and also she had severe, I thought what she had was severe depression, not just anhedonia. She was also on benzodiazepines and Adderall and an antidepressant. So with her, I said, okay, the first thing we need to do is we need to start taking you off your meds. And buprenorphine was, well, first thing, we need to treat your depression and take you off your meds, especially that Adderall. It wasn't easy. With her, it actually took a relapse, surprisingly enough. We were able to reduce her, we were able to reduce her Adderall. We were able to change her antidepressants. She started feeling better. She started getting out of the house a little bit, but it was still very hard. And then her grandmother died. Her grandmother, who was the one who kept the hot potato the longest, she died, and my patient relapsed. And ironically enough for me, she came off all her meds. So what I was trying to do, take her off Adderall, take her off benzos, she came off of all of them, and she was just using opioids. So when she came back to me, I was able to just start buprenorphine and gabapentin and not put her on that whole slew of meds that she was on. The good news about Ariel was that she did come back to me. Wesley was a difficult one. He actually did very well for a very long time. He had long periods of sobriety. He was raised by a middle to higher upper class family, affluent parents. He started using early, and when he was 17, he woke up in the middle of the night. Somebody pulled a bag over his head, tied him up, took him to one of those rehab centers. Have you guys heard of those? Where the parents pay. They're supposed to be illegal, I think. But he ended up in one of those rehab centers. He did stay sober for 3 years after that. When he stayed sober till 21, and that's when he relapsed on alcohol. When I saw him, he was 27. He had sobered up a couple times after that, but each time relapsed. When I saw him, he wasn't on opiates. He had severe anxiety, severe depression, severe ADD. I mean, poor kid, he had every imaginable comorbid disorder. He was very dedicated to the 12 steps, and 12 steps worked for him. So I did not put him on I didn't need to put him on buprenorphine. He was only drinking alcohol. He stayed sober for about, I forget if it was 14 or 18 months, and then he relapsed. And when he relapsed, he actually did relapse on opioids. This really made me angry. He came back to me. His house manager had given him buprenorphine and said, and he came back to me, okay, I've relapsed and I have, I don't know, 16 buprenorphine pills, and I'm gonna go lock myself up at my mother's house and try to detox on my own. I really tried to talk him out of that. I kept telling him, look, you're not a doctor, your house manager is not a doctor, let's work on this together. But he was adamant, didn't want to go back to rehab, maybe because of the trauma of the first rehab he had gone to. But he went to his mother's house, did not succeed. And then after that, he was in and out of treatment, never went back to inpatient. And then over time, I lost track of him. Maple, again, 100 milligrams of methadone twice a day and every other medication on earth. I believe she's a normie. So, and I'll tell you why. She didn't want to be on methadone. She used to come see me, and the entire time she would just sit there and was so drugged up. She just could not respond to my questions. She was so slow. We couldn't talk. And then finally, by some miracle, a doctor installed a nerve stimulant in her spine that she can control, and that's just nerve stimulation, no drugs involved. She slowly weaned herself off from 100 milligrams twice a day to 5 milligrams of methadone a day. I was so proud of her. And I mean, I worked with her. There was one time, I did not prescribe her methadone, but there was one time where she was going through withdrawals when she was at 5 milligrams a day. And all of a sudden, her doctors decided, the same doctors who were giving her 100 milligrams twice a day, at 5 milligrams a day, they decided she was drug seeking and refused to give her methadone. And she went into withdrawal. And I remember I prescribed her 10, 5, I forget. I think it was 5, yeah. So this poor girl has been through hell. She had so many symptoms that nobody can explain that we started, actually the entire medical staff, we started thinking that she had Munchausen syndrome. We were really worried that she was doing something to herself. And then after a while, we started thinking that maybe her mother had Munchausen by proxy and was poisoning her. No evidence ever found, and she's doing so well now that all those suspicions are put to rest. But this girl suffered, and she suffered because we were thinking inside our own box. If we can't explain your symptoms, they can't be real. Her pain doctors were just drugging her up. And by God, now, without all that methadone, we have such fun conversations. She actually is hilarious. And I love it when she comes and sees me. Dipper had the worst criminal history of all of them. The meth, he told me when I first saw him in 2015, he told me people are out to get me. He would arm himself, he would have knives. He was pretty sure that somebody was going to kill him. And he also has told me over time that when he was on the combo of heroin and meth, he wanted to hurt people. It felt good to be a criminal. When I saw him, he had been off the heroin, so we didn't need to use buprenorphine. He actually kicked it in jail twice and continued to use meth in jail, but couldn't get his hands on heroin. So we didn't need to use buprenorphine, but he also have told me stories. You know, doctors like to tell you, oh, you can't get high on buprenorphine. He figured out a way to use it IV and get high. So theoretically, you can't abuse it. He had severe, you know, it's so funny. When I was making the slide, I was reading his history, the notes that I took, and I kept thinking that I'm reading the wrong chart, because he's just not the same guy anymore. And I'm like, what, he was psychotic, he was paranoid. I cannot believe how much he's changed. I really think 12 Steps saved him, and he actually left the 12-step program and immersed himself in the church, but the church he goes to has a very strong recovery program, so he really benefited from that. He's not on we never had to put him on any medicine. He was against it, severe anxiety, severe psychosis. I said, okay, I'll work with you. Let's see if this resolves on its own, and it did. So the point I'm trying to make is that each person is an individual, and each person needs individual care. I want to just remind you, this was the baseline resting state of someone who hasn't done opioids, just a few receptors. Even after they are completely off the opioids, we don't know if the receptors ever go back to normal. First of all, the reward mechanism is missing for the rest of their lives. That is part of why people relapse, is that the wiring for the reward never forgets how much the person was rewarded with the opioids. But also, we have no way of measuring if the receptors go back to normal. I think they're doing rat studies. I don't know where we are with those. But we don't know what the state of the brain is after the person sobers up. So I want to tell you how my babies are doing now. Ivan is still on buprenorphine. Ivan is on 2 milligrams a day. We started at 16. We were able to get him down to 2. He actually quit smoking. He's a big 12-stepper, so I'm really proud of him for that. He goes about 3 times a week. He actually is taking care of some of his family members. He goes and helps them out all the time. His father passed away, and he managed that without relapsing, and that was difficult. And he's working. He's back in college full-time. He's a 4.0 student, and we have him on buprenorphine, and I would like to get him off, but this is a touchy situation because he's doing so well, and he's been on it for 6 years. So he falls under the buprenorphine maintenance category. And just so you guys know, I have in my whole practice, and I treat hundreds, I have 4 people on buprenorphine maintenance. So this is not representative of the number of people on buprenorphine maintenance. 2 of them are on the chart of 5. Ariel is still on buprenorphine. We've gotten her down to 2 milligrams a day as well. I'm very proud of her. She was taking 16 and still withdrawing. Her mood is stable. The anhedonia is gone. She's staying away from drugs. Her marriage has significantly improved. Our problem with her is that she wants to get pregnant now. And we have gotten her down to 2 milligrams a day, but my God, getting her from 2 milligrams to even 1.75 is quite a challenge. Wesley is my tragic story. He died of overdose a couple of months ago. It's actually quite sad. When I was making this presentation, he was still alive, and we just heard. It was devastating for me. And in this case, I always wonder, what would have happened? I mean, first of all, I keep going back to that day that he was in my room, and I'm like, I should have blocked the door. I should have just said, you're not leaving here. Can't do that, but I always wonder, would he still be alive today if he was on buprenorphine maintenance? Maple, she's doing great. She's off her methadone. What is she doing though? Cannabis. She's not, she's not, again, I think she's a normie. She hates the cannabis. It makes her mind go weird, so she uses as little as possible, and she uses it when she has her cyclical vomiting. She's actually against the legalization of marijuana because they're going to take the edibles away, and that's the one that keeps her from vomiting. So we're not sure how she's going to do with the cannabis, but she's now back to herself. She is going to be disabled for the rest of her life. Her disease is pretty serious, but she's working from home. She finished her GED. She's taking classes. I'm very proud of her. And I'm also very proud of Dipper. He actually works with us now. He got married. They just had a baby, and He's sober, he's not on any meds, he's doing great. So these are my 5 kids, and they go different ways. We have good stories and we have difficult stories. So buprenorphine maintenance is extremely challenging. Again, in treating hundreds of patients, I've been successful in 4 cases with buprenorphine maintenance. And the reason may be expense, it may be side effects. My patients actually tolerated well. I haven't had any of these side effects. It's the abuse. It's the abuse and the relapse that get me. I cannot, what the medical community has not, what we have not put our minds around is the addict brain. It's the behavior of the addict brain. You know, when somebody comes in for depression, for anxiety, for cancer, for high blood pressure, you give them the medicine, they take it as prescribed, they report back to you, they do what you say. Somebody comes in for addiction, they don't take it as you prescribe, they save it up and take it all at the same time. I've had so many patients whom I prescribed buprenorphine to, they would take it all week and go to work, and then on the weekend, you know, they don't take it Friday, and on the weekend they shoot up, and then Monday they start taking it again. So it's like, it's the one disease where the patient doesn't want to get better, basically, even when they come to you. The fact that they're in your office doesn't mean that I'm here to get better. The misuse potential, oh, and let's not forget they sell it on the street. That house manager gave it to Wesley. I mean, it goes wrong in all kinds of ways. They take it concomitantly with opioids. I cannot understand why, but they do. They use it irresponsibly. A lot of my patients take it for anxiety. I keep saying, look, this is not an as-needed anxiety medication. Stop it. So those are the patients I have to take off of buprenorphine. That's why I've had only 4 successful clients on buprenorphine. And then the other problem is, then how are we going to get you off? And again, the whole idea of maintenance is that you stay on it for long term. And you know, somebody with hypertension will be on blood pressure medication for the rest of their lives, but being on buprenorphine is not easy. They can't go on a trip without, you know, picking up their meds. They panic when they're out of meds. It's not the same. You know, when I run out of my headache medicine prevention, I get more headaches. I don't go through withdrawals and end up using. So, and then there's the social stigma. You know, was it Wesley? No, not Wesley. Ivan. Ivan has a sponsor who knows he's on buprenorphine. The sponsor is the only one who knows Ivan is on buprenorphine. He has been chastised so many times in NA that he has figured out, I'm going to go to NA, but I'm not going to tell anyone I'm on buprenorphine. Because they tell him he's not sober, they call him an addict, all kinds of things. And I've had a lot of patients just decide not to go to AA because they don't like to be treated that way. I respect Ivan for just figuring out how to deal with it. But you know, AA, 12 steps is all about honesty, but he feels like he has to be dishonest to keep going. So what do we do about this? We need to change our behavior. The medical community needs to change some behaviors, and the recovered community needs to change some behaviors. Find a doctor that understands the addict brain. Find a doctor that doesn't give the patient enough buprenorphine for a month and says, see you in a month. Okay, because what are they going to do? They're going to sell it on the street, they're going to abuse it, you're never going to see them again. Find the right doctor. The doctor needs to, when a doctor puts the patient on buprenorphine, we need to tell him, look, these are the side effects. The first thing I tell him is, I can put you on it, but it's going to be hard as hell to take you off of it. I always tell them, I know you want to detox at home, but I really recommend you go to an inpatient detox. I always recommend rapid detox in the beginning. I mean, I don't put people on buprenorphine unless they've relapsed several times and their lives are in danger. Maintain clear boundaries. My God, I suffer with this. My addicts call me in the middle of the night. I lost my medicine. What was it once? He had it in his shoe, and then all kinds of fun stories. And we need to address all comorbidities. If they're depressed, if they're anxious, we need to treat those things. So find the right doctor. And also, my God, there's also other doctors where a patient comes to me, he's on buprenorphine and benzodiazepines. And I go, and your doctor gave you this? Same doctor gave you both? Find the right doctor. And again, these are not patients that you see for 10 minutes and you give a prescription to. These are patients you need to spend time with. The doctor needs to sit with them, know their family, know their living situation, who's administering your medication, are you going to AA, who are your friends, how much time are you spending with people who are in their disease versus people who are in recovery. You need to know all of those things. And are you coming in and peeing in a cup for me? Because otherwise I'm not going to put you on this. So find the right doctor. And then on the recovering community, I've noticed that a lot of the clients tell me, when I went to the recovery center, I didn't know I was going to be taken off of buprenorphine. And there's a lot of conflict there. One of my worst horror stories was my client was on buprenorphine. They were giving him the wrong amount, so they were tampering with his meds. He was supposed to be on 2 milligrams. They were giving him 8. And then they decided, okay, it's time for him to be discharged, take him off. And I go, well, I can't go from 8 milligrams twice a day to 0. You need to keep him longer. Well, he's out of insurance, he needs to go. They dropped him off at a hotel. I mean, it was just awful, awful. And his case manager kept telling me, well, he needs to be on buprenorphine. No sober livings take someone on buprenorphine. I know that's not true. So I found a sober living that takes clients on buprenorphine, and the case manager would not let that client go to that sober living because the case manager had his own idea that this patient needs to be off buprenorphine. And when I said I can't get him off that fast, and when the patient said you cannot take me off my buprenorphine, he was dropped off at a hotel. So the staff really needs to work with the patient and work with the doctor. And also, I've had staff members discuss patients' disease status with other patients. Like, my God, if one patient gets tests positive for HIV or Hep C, the next day the entire recovery center knows. These things are so frustrating to me. And also the staff saying, well, you don't need 600 milligrams of gabapentin 3 times a day. I'm going to give you 300 twice a day. And I just cannot understand how these things are going on. And then in the recovery community, it would be really nice to understand that different people respond to medications differently. Poor Ivan, who has to lie to AA because he's on buprenorphine, is not benefiting from that kind of prejudice and that kind of judgment. Whatever, this idea that buprenorphine didn't work for me and I got a high on it, so you can't be on buprenorphine, is not a good idea. Or, it's not even buprenorphine. I had a patient who came to me, her sponsor told her, when my son was on Zoloft, he relapsed, so you need to get off of Zoloft. And I said to her, well, when my patient was in 12 steps, she relapsed, so you can't go to 12 steps. I mean, it's just ridiculous. Don't use your personal experience to give advice, and just have an open mind, think outside of the box. Doctors need to think outside of the box. In the recovery community, we all need to think outside of the box and understand that each individual needs his or her own level of care. And that's it. Buprenorphine is not for everybody, but it's for some people, and let's not judge them. Thank you very much.